you seeing communication with physicians at clinical? How does that compare to your experience in other clinicals? What do you think is the relationship between the physicians and the nurses in OB compared to what you saw in med surg? Is it the same? Is it different?
I think that they were like friendlier in a way, like they
Friendlier?
actually like talked more than, because the other ones were just kind of like, I'm here and I'm gonna leave, and they were just, I barely even saw the physicians at all the others.
Okay. So what physicians did you all see? What's that? I'm sorry, not the specific, not the names of the physicians, the types of physicians, I guess.
I saw like, there was like two physicians in the surgery, so you had like
The OB.
lead OB surgeon, and you had like the assisting surgeon.
Okay.
And the anesthesiologist.
So, okay, there's our third. A
So the
neonatologist, anybody have a resident neonatologist?
Yeah.
And I saw the
Practitioner.
So,
He did the same
so a
thing.
lot
C-sections.
more providers to kind of communicate and check in with each other. So who am I calling here? The OB. The OB is the primary care, but when I talk to the OB, I'm giving report on both mom and baby to the OB. Now, if something is wonky with the baby, I certainly would want to let neonatology or pediatrician know. But I could go ahead, so it's not just mom that you're talking about. So you need to also give this information in regards to the baby. The contraction pattern, why do I want to know that? What does that tell me?
What stage of labor is that?
Labor, okay? So, for example, I don't need to say very structured, the frequency is 0, the duration is 0, no, she has no contractions, she's not in labor. Or she's contracting every 5 minutes, they're lasting about a minute, they're moderate, she's breathing with them, she's requesting something for pain. Again, your verbal communication is to provide information to the provider. So did you ever hear anything about the evils of verbal orders and how you're not supposed to have verbal orders? But yet, what are you seeing in OB? A lot of verbal orders. We are really lackadaisical in our OB units, and it's that familiarity. Oh, by the way, your patient in 12, do you want PID on that patient? Sure. And the nurse automatically puts in all these standardized orders for Pitocin, but that was all the communication that occurred. There was no verification of 2 identifiers, there was no read back, there was none of that. So I think, there's some opportunities for quality improvement and safety there. I think if Joint Commission was ever there and saw that kind of behavior there, that would be concerning. So I think in practice, when you see things in clinical, it's sometimes you think, oh, that's really cool and awesome, but it's not always the best practice. And it's just because it's just habit, routine. The OBs are there a lot. OBs are with you thick and thin. Everybody has their own personality. Some days are good days, some days are bad days. A lot of our OBs are pregnant themselves. And so that puts another dynamic in there. But it's not just the OB. You've got anesthesia, so you have a CRNA or an anesthetist. Some of our facilities have 2 because they're so busy. The CRNA is doing the epidural on the floor. Anesthesiologist is doing the C-sections. If you work in a rural hospital, you don't have that. You have 1 anesthesiologist for the entire house. So you may have a patient on your labor and delivery unit who really wants an epidural, but anesthesia is in the main OR with a cabbage and can't get there until they get done with that cardiac surgery. So this is, again, just giving a picture of your patient and determining what the plan of care is. And I would say, for me, as long as my baby's stable and my mom is stable, the next thing I tend to want to talk about is pain. What's the plan for pain management, okay? You got a healthy mom, you got a healthy baby, but pain, because I want to know, can she have pain medicine? Can she have her epidural? So the OB, some of them, epidural whenever you want it. Other people, she has to be 4. It depends on the provider, okay? So once we know she's in labor, we'll move her to a room. We'll start an IV. So what labs do we need to get on admission? Well, now that is, it depends on your patient. In general, it's the CBC. CBC. Now, if I don't have any history on this patient, let's say she's here for the Breeders' Cup and she has no prenatal records and she's 38 weeks pregnant, I have to do all those initial labs. RH, type and cross, and hepatitis B, surface antigen, rubella, But for most of our patients who are established with us, the big one is the CBC, okay? Now the CBC gives us that preliminary data about white blood cell count, which may be slightly elevated, 11, 12,000. If I saw somebody's white blood cell count on admission at 25,000, I'd be kind of nervous about that. The book says that's normal. I don't find that to be normal. That's not my experience with the white blood cell count of 25,000, but I think it depends on the patient. Hemoglobin and hematocrit, that gives me a baseline, so I know where she is. If the patient is having problems with hemoglobin and hematocrit, the baby may not tolerate labor. The other thing is we have to watch blood loss with labor and delivery. So that is pretty normal. We usually put a nice big 18 gauge IV in. We usually start her on some lactated ringers or just some kind of generic solution. It's not necessarily to hydrate her, it's really more to give access, so if we need to give medications, we can do so. Do you have to have an IV? They like you to. So you can refuse, absolutely. Maybe you have the right to refuse, but the nurses really don't like that. The nurses at least want you to have a saline lock, and it's to have IV access, because if you hemorrhage, it's really hard to start an IV on someone who's in shock and bleeding out. Their veins, and it can be life-threatening. So we try to negotiate with patients. I get that you don't want to be hooked up to these things. You don't want an epidural. You don't want pain medicine. But can I at least just put a little saline lock there so if something should happen, I've got access. So you ask mom about her preparation for labor, what she's anticipating. And then one of the other big things to ask about is ambulation. Does she want to get up and walk around? At Norton Women and Children's, they have a portable monitor. I see it. I cannot think of the name of it. It has a fun name. Oh, got it.
Peanut? Or are you talking about like the train?
No, it's like a, gosh, what is it called? It's basically a portable monitor. It's like a phone. She wears the belts on her belly, but it uses wireless, and it transmits so you have continuous monitoring even though she's ambulatory.
Kind of like telemetry?
It's like telemetry, yes, yes. It works mostly okay. I've seen it in other hospitals as well, and that's the place I've seen it. So you might ask your clinical instructors about that at your specific institutions. But that's really nice because I can walk around the unit, I'm not tied down to the bed, but I can still get a tracing on the baby. The other thing I will tell you about ambulation, if I have a reactive non-stress test, my patient's in labor, we can unhook her from the monitor. She does not need to stay on the monitor continuously. So it's a normal healthy mom. So let's look at our normal healthy moms up here. These are all normal healthy moms. So this mom, she's a gravity 2 para 0. She's 38 weeks and 4 days. Her vital signs are stable. No significant medical history. Her bag of water is intact. So she has a reactive non-stress test. She's in active phase of labor. I can unhook her and let her walk around. Okay. As long as she's coping with her contractions well, she has somebody with her, that's fine. So let's talk about this patient. This patient's a gravida 3 para 1, 40 and 2. She's scheduled for induction. Now, induction is a little bit different because there's risk associated with induction. So when we have a patient who's getting induced, we generally do need to keep her on the monitor because the medication that we're causing contractions can cause the baby to not tolerate contractions because it's artificial contractions. So that's why, again, the portable fetal monitor is a good option for her. Now that's not to say you got a patient who's getting Pitocin, she needs to go to the bathroom. I can unhook the cables, let her go to the restroom, pee, and then get back in bed and hook her back up. But to be off the monitor, take the belts off her belly and things, we generally don't do that with an induction. For this patient, gravida 4 para 3, she's 39 and 5, she's here for a repeat C-section. She had a previous C-section ×2, which first one was for failure to progress. So she tried to labor, but didn't get past whatever. The second one was scheduled today's schedule, she has no complications. Sometimes we don't even put those people on the monitor, like they just get fetal heart tones. We check fetal heart tones when they enter the OR, and that's it. So you don't really have a lot of tracing there. So as a student, you're kind of nervous, like, well, they didn't even put the contractions on, so I don't know if it's reactive or non-reactive. I couldn't really tell, because they just get a little snapshot of the monitoring. Okay. So that's another thing to think about. It's very different. It's facility specific and OB specific about ambulation. All right, so cultural competency. We're going to see women from a lot of different cultures. I've given you some different pages in the textbook that are helpful to review. This is in the very, very beginning of the book. And some of this you'll remember from 206, when you did cultures in 206 and cultural competency. So one of the things that I always ask about is who should be present in the room. Some people want to have extended family. So what happens if we want more than 3 people in the room, and the policy at our hospital is 3 people? Well, I'll be honest with you, a lot of labor rooms are strategically placed, and if we know somebody has a large extended family, we will put that patient in one of those larger rooms so that 5 or 7 people can be in a room. I have been in a delivery where 11 family members were present. It was really crowded and hot. So why is labor delivery, why are we so fussy about the number of people in the room?
You never know what could happen for one, you be able to move or have a move.
So in event of an emergency, if I need to get mom out quickly, it's really hard.
More people that might pass out.
Exactly. So as a nurse, I really need to be tuned into taking care of mom. Now we also have baby. It's really hard for me to also take care of Aunt Joe and Uncle Jim over here who are not feeling so good and a little queasy and haven't had, their blood sugar's low because they've been in the waiting room all day. But it's a safety issue. So if you try and frame it that way, the other thing is, when you have that many people in the room, that's not factoring all the staff that then come in the room. And again, it poses a lot of safety risks. So what I usually try and do when somebody tries to have kind of that many people in the room, I try to encourage them to kind of rotate out, give some time for the family to bond. Let's give her some privacy. We don't know how long this will take if you all want to rotate in and out. Some facilities, they actually will not allow in and out of the room while pushing. So it's like once we start pushing, nobody can re-enter until we come back out. Because again, it's a little bit of a risky time, and they want to be able to resuscitate the baby without people gawking and looking all over. But I will tell you, there are other hospitals, they're like, come one, come all. You want 11 people? Bring them on down. So it's very individualized, but I think it's something that as a woman, if it's something really important to you, you definitely want to have that conversation during pregnancy and choose a site that is amenable to what you want. Okay? I'm biased. My background is hospital OB. We have really medicinized OB. We make women having babies seem like they're sick and have illness, and women have babies all the time. It is a normal physiologic process. So I think some of the things that we see here in our clinical experiences, you think, gosh, childbirth is just like this, but it's really not. There's a lot of variety. The other thing about culture is some people have beliefs about what they can eat and drink during labor. So you may have a person who wants hot liquids, so when you bring your cup of ice, that seems very offensive to the patient. They'd rather have hot tea because they consider childbirth a hot condition. Some patients want the first words that the baby hears to be the father's voice. So it would be very disruptive for you to say, congratulations, you have a, and that's not what they wanted. Some people get really upset about the gender of their baby. They were wanting a specific and they got the opposite. And so we have to kind of work through that. So there's just a lot of things that we have to be mindful of. But I think the big takeaway with culture and OB, we're not the drivers, the patient is. It's patient-centered. We try to do whatever we can in terms of what the patient wants. Now, in some cases, though, we have to be, again, a little bit cautious because let's say you have a patient who does not want a blood transfusion. So we need to have some really frank conversations about that because, again, we do see that in OB. So, for example, I've had a patient, it was a Jehovah's Witness, absolutely under no circumstances, no blood. Hemoglobin is like 5.6. Sick, sick, sick. kidneys are shutting down. She never took blood. Came out of it. We actually transferred her to ICU, but it was a really scary situation. And we just need to know those things ahead of time. When patients come in, they often sign consents. It's consent for care. In OB, we often include consent for blood transfusion and consent for C-section kind of all at the same time. That can be kind of scary if patients don't know that that's coming, but it kind of takes care of that if there's an emergency situation. We're not frantically waving a piece of paper in your form or in your partner's form saying, sign this form because your partner's getting a C-section, emergency C-section or something like that. Okay, is there any questions about culture that I can answer for you? Again, you just don't wanna assume just because somebody has a certain ethnicity that they follow certain religious practices. A lot of people pray during childbirth. When we have a baby that dies, sometimes they might ask you to baptize the baby. And so certain facilities, they'll actually train you about how to do that, so you might be able to baptize the baby. All right, so during the first stage, all of the phases of labor are in the first stage. So when we talk about latent phase, we're happy, I'm glad to be here, I'm feeling pretty good, things are moving along, I can chat with my friends, I can check my phone. Active phase, I'm getting a little bit more irritable. I'm getting restless. I actually can't talk. During a contraction. Things change all of a sudden. I get a little bit more serious, a little bit more focused. People around me, I'm still okay, but I'm kind of getting tuned into what's happening here. It's like, okay, I know we've talked about this day, but I think today's the day, and I think it's happening, like, right now. And so you have to, again, reassure the patient, give them support, give them space. You don't want to overwhelm them, but we also need to be prepared for different things that will happen. And so this is a time when we try to do things like pain management, and again, hopefully, it kind of moves sequentially and evenly. But sometimes what happens is you were 3 centimeters, and now you're 8. So you kind of went from latent phase to transition phase in like 30 minutes. And so there was no active phase. You were just like, the baby's coming. It sounds like that's kind of what happened here, you know? Transition phase, the shortest but the most difficult. And really uncomfortable, lots of verbalization. Some nurses really don't like the patients making noise. Like they make faces. I'm like, she's in pain, she's hurting. But they think that's a big deal. I think it's a pretty common thing, and again, I don't think there's anything wrong about that. Now, we do try to avoid women screaming like profanity. That would not be ideal. That could be kind of disruptive in things. But I think this idea of control, breathing, kind of present in the moment, but encouraging women that, again, we're trying to get to complete, and then we can start pushing and you'll have the baby. And for some women, in this part, they feel very out of control. It's like, I can't, they don't even realize what they're doing, they don't realize what they're saying. They may not want to be left alone, but they also don't want you to touch them. And it literally feels like somebody is down there and it's just gonna come apart, and you're scared to death that you're tearing or you're ripping, but everything is just stretching as we're getting prepared to start to push. I do not like this table in the book. It is too confusing. There's too many numbers. Blech. So I would simplify this a little bit. And you'll notice that these numbers don't agree with the slide in another PowerPoint, and you're absolutely right. They are not identical. Early or latent phase, the contractions are far apart. They are very short duration. When we get into active phase, notice now we are at 2 to 5 minutes every 40 to 60 seconds, and they're moderate to strong. Transition very close together, but they also are longer in duration. Do I continue having contractions in stage 2? Yes, because I have to have involuntary with voluntary together in stage 2 to deliver. So, if my patient's on Pitocin, I've been giving Pitocin to have contractions, I keep the Pitocin on while she's pushing. I don't turn it off. If you turn it off, the contractions go away. So you need both involuntary and voluntary to deliver the baby vaginally. So this labor progress, notice again, it's like 1.2 centimeters an hour, 1.5 centimeters an hour. What's the take-home point? People having their second, third, and fourth babies are gonna go faster than people having their first babies, usually. Now, not always. Sometimes those first-time moms will surprise you. So let's look at our two patients up here. Has she had a baby before? Do you have enough information to know if she's had a baby before? You do. There's no para. So the previous pregnancy, something happened, whether it's miscarriage, abortion, or whatever. Does that impact, does it matter if it was gravid 1, gravid 0, or gravid, no, it's not a risk factor. It doesn't matter if she's a G3, P0, if she had infertility, that was an early pregnancy issue, it's not an issue for us now in labor and delivery. So this mom, 38 weeks and 4 days, it's her first pregnancy, so I don't really know, but I would anticipate this mom's gonna take a little bit longer than this mom. She's had a baby before. She's being induced. She had a vag delivery 2 years ago. Her labor was 8 hours the first time. So second babies are often faster. Why would they induce her? Well, believe it or not, it may be to have it be very controlled, so they can monitor her very carefully. The other thing is, there's very little fluid there around the baby, so the baby's at risk. She's past her due date, so let's go ahead and get her delivered, but we can do it in a controlled fashion because of this history. She had a good-sized baby before and a little bit of a tear. Is that a risk factor for this pregnancy? Not really. So again, these are approximate, and remember that we are letting our patients labor down. So a lot of times they're getting to complete, but we're not starting to push right away. And that has to do more with station. All right, I have some pictures here for fetal monitoring. So I like to do my baby first. My baby's kind of my priority here when I look at the monitor. So I'm gonna say that baby's baseline is right about 140. So I'm looking at this number over here, so 120, 130, 140. Okay, it's mostly there. I try to look between contractions. I would describe that variability as moderate. I do not see any accelerations, but I also do not see any decelerations. So that would fall under category 1. It's a fine strip. It is a non-reactive NST, but it is a negative CST. I don't really need to do anything with this strip. Mom's okay. Everybody agree with that evaluation? You want me to swing through it again, or? Sure, I'm happy to do so. It's a lot really fast. So the first thing I look at is the baseline. I would say this baby's baseline is about 140. The second thing I looked at was variability. I described the variability as moderate. Our terms that we use to describe that are absent, minimal, moderate, and marked. Of those, I would discard marked. Don't worry about it. Okay. But this is moderate. The definition of moderate variability, 6 to 25 beats per minute. Okay. So the next thing I look at, presence of accels. I don't see any, so I'm like, but it's not horrible, but there are no decels. So I look at 4 things. I do baseline, variability, accels, and decels, and if you look at your intrapartum assessment form, that's exactly what it says on there. Okay, so that's the first thing I do. The next thing I do is contractions. So with contractions, I have frequency, duration, and intensity. Resting tone. Let's talk a little bit about resting tone. Resting tone is between. So with an external monitor, the number doesn't mean anything at all. So if I have resting tone and my patient has an external monitor, that's by palpation. So I just describe it as soft. The number doesn't mean anything. So frequency, I'm gonna count from the beginning of the contraction to the beginning of the next contraction. So see how this is it's not here on the red line, the thick red line to the thick red line is 1 minute. Each one of these blocks is 10 seconds. 10, 20, 30, 40, 50, 60. Okay. So I'm gonna try to stay in the same spot. So 1, 2, 3. 1, 2, 3. So right around 3 minutes. And notice I'm loosey-goosey with it. I did not say 180 seconds. Frequency is in minutes. durations in seconds, so I count the blocks underneath. So again, do I count that? Do I not count that? If you're really type A, this is gonna stress you out, okay? So I would say 10, 20, 30, 40, 50, 10, 20, 30, 40, 50, 60, 10, 20, 30, 40, 50. So around 50 to 60 seconds. But Ms. McNeely, you didn't count that little triangle. I know, because the nursing care doesn't it doesn't change if it's 50 seconds or 60 seconds. All right? Now, intensity, I cannot tell from this monitor. I have to touch my patient. So the frequency is every 3 minutes. The duration is 50 to 60 seconds. The intensity I'm gonna palpate, mild, moderate, strong. And the resting tone would be soft, is how I would describe it.
So the intensity doesn't have as much to do with her verbal, like how it feels to her, it's more so your palpation? So I remember.
It
hearing something
depends.
about asking
Because
for
you
stuff.
could have a really, so someone like me who's obese and has a lot of sub-Q tissue, I may be having moderate contractions, but they feel softer because you're feeling all that sub-Q tissue. The other thing is, if my patient has an epidural, she doesn't have that sensation of the difference in intensity. So it's a data point, it's somewhat subjective. Just because you palpate strong contractions, but if she's talking and she's happy and you're like, oh, I'm having a contraction, just because they feel as hard as your forehead doesn't mean that they're necessarily strong contractions. Does that make sense? I don't feel I've answered your question, so ask me again.
Okay, so with, my clinical instructor says with the external monitor, you can't judge the intensity, so I think she said you ask the patient what you feel the intensity is. But
Okay.
you said it's by palpation, so
I
I was
would
wondering
do-
if it's one or both.
I would do both. So you talk to your patient because the way it presents, plus I also want to feel. So in other words, I would want to lay hands on my patient's uterus because you should be able to feel it get firm and hard and then relax.
Mhm.
So I think the answer to your question is both. Okay.
What did you mean by like the soft fetal heart tones?
Soft resting tone.
Oh,
So
okay, I see
right
what you mean.
here, it should be soft. It should not be firm at all.
Okay, I think so.
And I'm always feeling the fundus. So it's not the whole uterus because contractions start, remember. That's okay.
Someone's at my house.
Oh, no. Do you need to go take care of that?
No, it's fine.
Okay. Is it somebody who's supposed to be at your house?
I don't know who it is, that's why I was watching.
Oh my gosh, that's kind of scary. Do you have nests?
Yeah, I
Oh
do.
my gosh, that would freak me out. No. I'm worried. Are we okay?
Yeah.
Did you say go away?
No, I didn't know he could hear me.
Okay. So we always palpate it from the fundus. So up at the top. You had a question?
Yeah, I was just gonna say, so like in like a question-based scenario for something like that, like we would ask them, but we would just have to know that like if it's an epidural, that like the correct answer would be to actually palpate it, right?
Yes.
That would be, okay.
Yes. Yes, and I think as a student, a lot of times you don't see the nurses, but when they go in and adjust the patient, they're feeling where to put the toco, because the toco should be where you're and that's what they're actually doing is they're palpating and checking, and they're putting the toco there.
But the toco can't actually tell us intensity.
Correct.
Okay.
Toco only tells us frequency and duration. Yep. I'm really glad we're having this conversation, because we really wanna clear up things that are foggy, because the nurses are not always articulate about, they're thinking about what they're doing and why they're doing it. So that's why I need you to be brave. And remember, I'm an old L&D nurse, so I know how they are. Okay, so we're gonna move to the next one. Now again, this strip, remember it came from our perinatal software, it's not off a real patient. There's some things on this strip that are different than our previous strip. So here's where we were, okay? So we continue to monitor a patient. So I start with the baseline. I feel like the baseline is still the same. I don't really see any changes there. I'm happy with my variability. I'm still gonna call that moderate variability. There's wiggle. So in other words, if it were absent or minimal's like less than 5 beats, 3 to 5 beats, there's just the little tiniest wiggle. Absent looks like a straight line. So I'm gonna call that moderate. But we have some what I would call variables. Do you see those? And then this little booger right here, we're gonna say variable. And the reason why is because I have moderate variability. So theoretically, could I have a moderate variability and late D cells? Sometimes. That's one of those quirky strips. I would never ask you as a beginner about something like that. Because the variability looks good, I feel like this baby's well oxygenated, so I don't really think that's a late D cell. I think it's just a little variable. And these variables are very, very slight. And they're really, I would even hesitate to really even, like this one, I wouldn't even really call a variable, maybe here, but you're looking at a D cell, it only went down to 120, and it's maybe 15 seconds. It's really not any, so there's nothing here. I wouldn't be like hopping up out of my seat, turning and reposition the patient. I would be drinking my coffee and talking to my friend who's got the patient in room 4. I just wouldn't get real excited by that. So even that, that does not make me nervous as an L&D nurse. Ooh, that looks different. So now I have a different baseline. Do I need to be concerned?
Yeah,
Yes.
there's some long D cells.
So I hear some yeses. I should be concerned. Do I have any differing opinions?
I thought it was similar from the class one.
Looks like a variable.
So we think we see a variable.
I see like early D cells with moderate variability,
So I hear early D cells in so what I would do, first of all, what's the baseline? So I'm gonna look at the baseline between contractions. I think the baseline is right around 120-ish, okay? We don't use baseline like 123, it tends to be in 5s, 120, 125, 130, because the nursing care doesn't really, so sometimes you'll ask the nurse and she'll say, oh, it's 125, 130, oh, it's 120, 125, kind of vague. Moderate variability, yes. I like variability. So right away, I'm not that stressed about, I don't think this baby's in a bad place because I have moderate variability. These, believe it or not, are actually considered by the software earlies, but I can see where you would think they're variables. And so I have fetal heart rate of 120, I have moderate variability, I have no accelerations, and I have early D cells. I am not worried, that is normal, I don't need to do anything about it. Early D cells are from head compression, so hopefully labor has progressed. You want me to do it again one more time? Or do you feel good about what you see up here picture-wise? So how do you distinguish earlies from variables? The baseline's lower here, so yes, they're going down, but see how it's kind of a gradual decline and it returns back up. If it was sharper and came back up suddenly, the other thing is, see how it's consistent? Variables are more irregular and inconsistent. So to me, those are early/variables. They're not quite as subtle as I would like them to be. I'm kind of stuck with the software. So we get to that, and we hope our patient is complete. What the heck does that mean? Complete dilation, complete effacement, okay? So again, if this was the progress of my labor, am I concerned about how this baby's going to be from a resuscitation standpoint? I'm not seeing anything out of the ordinary. So in both situations, with both of these moms, I'm preparing for a normal, uneventful delivery. This patient is never getting there, because we're not gonna let her labor. Let's say this patient is a scheduled C-section for next Friday, but she comes in today and does this. Do we let her deliver vaginally? Usually not. They would take her for an unscheduled C-section because she's in labor. Okay.
Can I ask you a question?
Sure.
What was the VSS over there on the
Vital
chest?
signs stable.
Okay.
Also, so if we saw a sign like that and that was what
supposed to be for a scheduled C-section, there's no need to do a badge exam. Cause she's, laboring, so, but I can tell you, never say never, so you might have a patient who's supposed to be a scheduled C-section, and she comes in and she precipitously delivers vaginally, whoops. But if mom's okay, baby's okay, it's a done deal, there's nothing really you can do about it, but there's not a need to do a badge exam. Because if you do a badge exam and then the water breaks, and then you get a cord prolapse, it kind of causes a lot of problems, so. A scheduled C-section who's in labor, they're gonna go ahead and do the C-section. They're not gonna let her labor, usually.
Is it because there's usually a reason for the C-section to be scheduled?
Because what?
Is it because there's usually a reason for the C-section to be scheduled?
Correct. So in this
Okay.
particular situation, she's had 2 C-sections, so the concern is uterine rupture if she labors. In this particular stage, if your patient had an epidural, they may have rested, so they're able to participate. So that's why we really wanna have them kind of conserve their energy. Patients who are going natural, you wanna make sure that, they've stayed hydrated, that they're comfortable. But a lot of patients going natural, they actually like this part because they can do something with the pain. And so kind of pushing at the pain, pushing at the pressure, but you only push when you feel the urge to push. And so if the patient doesn't feel any, so we don't have her push all the time. And again, when you push and bear down, it needs to be kind of guttural, very low, almost like you're having a bowel movement. During this particular stage of labor, which is stage 2, we wanna assess maternal vital signs every 5 to 15 minutes. And this says fetal heart rate every 5 minutes. That's if we don't have continuous monitoring. So I have a woman who doesn't want any of those belts. She doesn't like it. It's uncomfortable to her. So I can take the ultrasound and every few minutes or between contractions, I'm just gonna spot check and just listen to the fetal heart tone. I'm not always getting a strip, but I just wanna listen and make sure that fetal heart tone is good. It's between 110 and 160. I hear some variability there in terms of when I listen. But I don't have to have the belts on her the whole time. She's going natural. She can tell us when she's having a contraction, so that way I know how the baby's doing. Believe it or not, there are some people who deliver a baby with no fetal monitoring whatsoever. Have you ever heard of such a crazy thing? Yes, yes. All right, the other thing is people can deliver in all different kinds of positions. In general, in the hospital, because of epidurals, what you will see patients are in semi-Fowlers, you have a dorsal recumbent. So let's talk a little bit about stirrups. Who had patients in stirrups on Wednesday? Anybody not in stirrups? Because it went so fast, there wasn't time. Do you have to be in stirrups?
Apparently not.
Apparently not.
She just had a pillow with one leg over it, and that was all she needed.
You don't have to be in stirrups. Why do they put people in stirrups?
What's that? To help them push?
Well, yes, it kind of keeps the legs out of the way, because when you have an epidural, those legs are kind of heavy, and they can kind of be floppy, and they kind of get in the field, so it kind of keeps those things out of the way. Did anybody see the OB provider take the bottom of the bed out? Okay. Some people take the bottom part of the bed out, and there's kind of this big tray there. Some people leave that part of the bed there, so that's not always a requirement either. The whole thing about being up in stirrups, it's kind of for the patient, gets in a little bit closer. Sometimes when you say pull my knees back, it's kind of far to reach down there and grab that knee, especially if I don't have a helper. We have to be really careful with being in stirrups for a long period of time, because we can have some nerve damage right behind the popliteal space. So I certainly would not want my patient up in stirrups for 2 hours and 3 hours and that sort of thing. So it tends to be kind of one of the last few pushes that the patient's doing as we're preparing for delivery. The other thing when it comes to pushing, is the doctor there? It depends. We can start pushing without the doctor, absolutely. So let's look at our patients. First time mom, even if she's going natural, she may have to push for 30 minutes, an hour. The physician is not in the room the entire time. The physician only comes in a lot of times for the last couple of pushes. This mommy, physician will probably probably be there when we start pushing, because we have a fast labor, she's a multip, her pushing is likely to be faster, okay? But you can start pushing without the physician present. Sometimes the physician will say, I'm in the OR, I'm finishing up this case, do a trial push. Sometimes they're nearby, so they're in a call room or something like that, but they're not actually physically in the room. Who is? The nurse. The nurse. Okay. So this talks about sitting. I just want to bring up hands and knees. So delivering a baby on hands and knees. So the patient's on all fours in the bed and can deliver the baby that way. A patient with an epidural would not deliver that way. They're too numb. There's no way to get them in that position. It's unsafe. So again, this just kind of shows you, usually we will call the physician right around here. So we see the baby crowning. Notice the bulging perineum. And then very quickly, so the delivery cart gets set up. It's often kind of set up in the room. The tech will come, get everything ready. But basically the physician will come in, put gloves on, catch the baby. Midwives do things a little bit differently. Midwives tend to spend more time in the patient's room and are often there providing more support in labor. And that's why some women want to have a midwife as their OB provider. So the head comes out. Why is this towel here?
To be able to support the head maybe a little bit?
Support the head. The big thing here is the support of the perineum. It's trying to prevent tearing of the perineum. So we're going to kind of ease out very gently the head. The head is out, so you'll see a bulb suction there, and then easing the head out. And again, this looks like he's pulling or she's pulling on the head, but again, it's just kind of easing those shoulders out to hopefully prevent tearing. Sometimes there's a big gush of amniotic fluid. So if you've not seen a vaginal delivery and you're getting ready for the baby to come, you really don't want to have your face really close by because you'll get splashed. You don't need to turn away. I do always tell students though, some people, OB is not their thing. And it's like, okay, there is way a lot of blood and there's just stuff going down there that I just really don't want to see. That is okay. You can turn this way and direct yourself and be support to the patient. The other thing is, as a student, you can often lay eyes on the partner, the dad, or somebody who looks very pale and is like this, and you are helping take care of the partner so they don't pass, because a fall in the middle of a delivery is a very, it's an icky thing, a lot of documentation, it's like a headache, so. We wanna make sure our patient's okay and our family's okay, because it's all about care of the family, not just mom and baby. So we deliver the baby, woohoo! What do we do when we deliver the baby? The first thing we do when the baby comes out? Congratulate mom and dad? No. Stimulate, I would say dry. Dry the baby off. And that stimulates the baby at the same time, but I'm drying the baby off very rapidly. I need to make an assessment in that first minute of life about whether that baby's okay. And if that baby needs additional resuscitation. Generally, babies who have APGARs of 8 and greater do not need intervention at the first minute. If I have an APGAR below 8 at the first, so it's 1 minute and 5 minutes. Your paperwork, does it have 1 minute, 5 minutes, and 10 minutes?
It says all three.
Okay. We don't always do 10-minute APGARs, so I would not stress that if you don't have a 10-minute APGAR, don't worry about it. That's only if there's abnormal 5-minute APGARs. So during the third stage, we want to try and wait before the patient, before the provider cuts the cord. So this is called delayed cord clamping. And so what's happening is there's still pulsations of blood from mom through the placenta, through the umbilical cord to the baby. And so we really want to make sure that continues. We want to wait to cut the cord until that pulsation stops. And the reason for that is that last little bit of volume there helps support the baby. It helps them in terms of oxygenation. We were concerned initially that fluid overloaded the baby, but we actually found that it prevents anemia, and babies make the transition to extrauterine life better when they have delayed cord clamping, okay? So again, it's not right away, ideally. Now, sometimes you'll see people do that, but we wanna try and wait. You clamp and you cut between, and then, some hospitals send everybody for cord blood gases. So they have a section of cord, they put it in a kidney basin or emesis basin, and then somebody's there is getting cord gases. Sometimes you see the tech, putting a syringe in and drawing cord gases. Cord gases are not necessarily routine. Some hospitals do them on every baby. Some hospitals only do them on sick babies or babies who needed to be resuscitated. Okay, God bless you. Anybody, I did not hear about this from the instructors. Anybody have any cord blood banking? It's kind of a new phenomenon. It's important to know if the patients want to donate cord blood or save cord blood, because this is when we get it. And so parents have started doing this where I can save cord blood at the time of delivery. It has stem cells present in it, so then later in life, if my child has leukemia or some type of disease, we can use those stem cells to help the baby with later health conditions. So we have to harvest that. There's a technique that has to be done at the time of delivery. So if you want to know more about that, that's actually a link to cord blood donation. You might have parents ask you about that. So hopefully we get the placenta, and most of our placentas are early express, so they deliver within about 5-ish minutes or so. What happens to that placenta? Some, very few get sent to pathology. The reason it would go to pathology is we're concerned about some type of chromosomal defect, there was a problem with the baby, infection. Most of them go in the garbage. They just get disposed of. Some people want to keep their placentas. They eat them. Yeah. Some people dry out the placenta and turn it into powder, and then they put the powder in tea. The CDC frowns upon this action. They do not recommend it. There's no nutritional value from eating the placenta or using the placenta, and there's concern about infectious processes. But there are some folks who have some very strong cultural beliefs that that is part of your body. Some people want to bury the placenta. And it's, again, their culture and their religious beliefs. So it seems odd to us, but we would want to know that ahead of time, and we would want to make sure and honor that request. So you have a patient who says, I want my placenta. I'm like, okay. So we have the placenta pan, we put a lid on it, and we put it in a bag and we give it to her. Okay. So when people ask me what happens to my placenta, it just gets incinerated with biohazardous waste. It doesn't really go, they don't do testing, secret government testing on it or anything like that. It doesn't get donated to, hair salons and all these other crazy things, so. All right, you need to know these medications. Put a big, giant highlight on those medications. So Pitocin is by far the favorite. Pitocin is the first drug of choice. Even if the patient got induced with Pitocin, I am just too popular today. She gets Pitocin after delivery. She gets Pitocin after delivery. Good answer. All right. And we want a lot of it, and we want it really fast. Because what happens is all those blood vessels are open, we have increased cardiac output, is basically a pipeline wide open, and we need it to shut down as rapidly as possible. So I give Pitocin, and things don't really work. I still see lots of bright red blood, and that fundus is boggy. Boggy's a bad thing. I don't like boggy. Boggy's mush. It's like rubbing into pudding. It's very scary when you have a boggy uterus, because you're massaging and there's nothing there. Sometimes what will happen, you will see people cup the uterus. They actually use 2 hands to massage the uterus. In some cases, this is really scary. You literally feel like you're pushing against her backbone. It's like you're using the backbone and your hand to press her uterus, because it's just, it's bad. Now, these medications, again, ordered by the physician, so I'm not deciding which one is used, okay? So I have Pitocin, usually IV. Methergin in this stage would be IM. Cytotec is a tablet, so it could be given rectally, and it's absorbed through the rectal mucosa. It could be sublingual. For this purpose, I tend to see it rectally rather than vaginally. Now, Cytotec could be used during labor to stimulate and induce. When we use it for this purpose of postpartum hemorrhage, we use a lot more of it. So for example, in labor, we're gonna only use 25 micrograms. Here we're gonna use 600 or 800 micrograms of Cytotec because she's hemorrhaging, she's bleeding too much. These are not routine medications. So if you found out that your patient got Cytotec after delivery, she was bleeding too much. So I mentioned Cytotec, I mentioned Methergin. The need to know about Methergin, we do not give it to patients who have hypertension. That is the big thing about Methergin. It's PO and IM, but again, in this situation, more than likely it's gonna be given IM. So let's talk about Hemabate. I hate Hemabate, but boy, it is the last resort. It makes people really sick. It will make the patient, she can run a fever, she can have profuse diarrhea. But again, it's meant that she's having life-threatening hemorrhaging occurring. And it's given IM. There are a lot of contraindications with these two drugs. They're old, and we really don't like them. But again, when we're using these drugs, it's because mom is bleeding so much, her life's at risk. So this is on the baby. We would want to see respirations between 30 and 60. Honestly, new babies tend to have fast respirations because they're crying and they're active. Heart rate is the same as it was in fetal heart rate. Temperature is critical. So again, keeping your baby warm is a very important priority after delivery. You're gonna do a quick head-to-toe assessment, and these would be the things that you would see. I can do a quick Ballard scale. During clinical, you're gonna do a Ballard scale. Don't feel like you have to memorize that, but there's simple things, like a term baby, the air cartilage should pop back really nicely, okay? With a term baby, when you all go to newborn next week nursery, play with the baby's hands, their little fingers will more than likely touch their wrist. It's really cool. You and I, we are preterm babies. Our fingers do not touch, okay? But I'm term with scarf son because I'm preterm with scarf son. My arm is really floppy. Term babies, when you try to bring that arm across, they give you resistance. You wanna see that. You wanna see good tone. That's a term baby. Preterm baby's kind of weak and floppy. With mom, we're gonna assess the vital signs every 15 minutes. That includes checking her fundus. Where should her fundus be? Midline. At the umbilicus. What if it's lower? That's okay. I'm not worried if it's lower. I just don't want it to go up. If it goes down, it's okay. So let's talk about this mommy. Today, her baby was 915. Woo! That's a good sized baby. Her fundus may not be at the umbilicus. It might be a little bit above. If it's firm in midline, I'm okay with that. And it should be shrinking down each day, so it won't stay up there. I'm gonna keep an eye on it, because again, big baby, multip, she was induced, so I see lots of data points for risk for what? Big baby, induced, multip, risk for dehydration, maybe, I'm thinking hemorrhage. I would say, when I think of deficient fluid volume, yes. Maybe because I just came from 205, I'm thinking dehydration because I was talking about diarrhea.
Well, I was thinking hemorrhage, but she just said we use deficient fluid volume.
Yeah.
in the-
Because
Yeah.
again, with hemorrhage, you could also have decreased tissue perfusion, you know, so. Lochia. It is what comes out after the baby comes out.
A mixture.
It is not bright red blood, but we have rubra, serosa, and alba. And so it's darker red, it kind of looks like menstrual blood, but it's heavier than that. And we put pads on the patient, the patient might say, I thought those were that's a diaper for the baby, and what you're putting on me sure seems like a diaper. and we're having to change it frequently, because she's bleeding a lot initially. So this is one of those times when my assessment at 1 hour of delivery is something is normal at 1 hour of delivery. That's different than 1 day after delivery. So I may be bleeding kind of a lot at 1 hour after delivery, but it should be easing up. 1 day after delivery, I shouldn't be passing big clots. I should not be having to change my pad frequently. We really want that to slow down. And so our concern is if she saturates a pad within 15 minutes here. We don't like that. Okay, so that's why we check her every 15 minutes. Logic. You wanna have time with the baby. In her perineum, we might put an ice pack on her bottom. Does this patient need an ice pack on her bottom? She didn't push, didn't have vaginal delivery, so there's really no need. She has a Foley catheter. Does she have a Foley catheter after delivery? So my folks who had vaginal deliveries on Wednesday, did you put a catheter in after she had a baby? Yes. No? Yes. The classic, it depends. And some of it is facility policy. Some of it has to do with whether your patient had epidural. If we're concerned about hemorrhaging, we're gonna put a catheter in because we wanna keep the bladder empty so she doesn't hemorrhage. So there is no clear-cut answer to that question. Does she have to have a catheter? Not necessarily. So let's say she had a Foley catheter, we took it out as she was starting to deliver the baby. We are concerned her bladder could fill up, but if she's able to void on her own spontaneously within about an hour, hour and a half after delivery, then there's not a need for a catheter. Okay. All right, once mom has a baby, it's very common to have shivering, so we give her nice warm toasty blankets. You sometimes see that with epidurals as well, a lot of shivering. Give her something to eat or drink, and we need to be really cautious with our first ambulation. Some hospitals, we ambulate the patient in labor and delivery before we send them over to mother baby. Some hospitals, we put the patient in the cart, we don't get the patient up in labor and delivery, they do that over on mother